I'm going to talk to you about a small pilot project that we've undertaken looking in the ER low category, and again, particularly whether we can predict response to chemoimmunotherapy in that group. So the established guidelines for defining whether a tumour is ER positive are up here. So I'll just say this is all going to be HER2 negative tumours. So the traditional guidelines from ASCO CAP back in 2010 defined it as an ER or PR score greater than 1%. Which was based around endocrine sensitivity for that. Now, in the UK, we tend to use something called the Aldred or Quick score, which actually is a combination of percentage positivity and the intensity of the staining, and it runs from 0 to 8. And in this binary system, a score of 3 or above on the Aldred counts as ER, PR positive. In terms of negative scores, less than 1%, or an ER or an Aldred score of 0 to 2. And this is important, this decision between whether we're treating it as ER positive HER2 negative, or triple negative, particularly in the early breast cancer setting, there's quite different routes to the treatment. So with the ER positive, we tend to give anthracycline taxane chemotherapy, and then obviously followed by endocrine therapy, sometimes in neoadjuvant, quite often in the adjuvant setting as well. However, and so if you give it in the neoadjuvant setting, you get a pathological response rate, which is pretty low, actually, about 15%, if you take all comers from that. The triple-negative breast cancer, based on the Keynote 522 study, which was published a few years ago, the standard of care now is chemotherapy plus immunotherapy. And that chemotherapy, again, keeps the taxane, anthracycline taxane backbone, also adding carboplatin alongside the taxane. And so there's quite a difference in actually how we treat these two groups. So determining which one is most likely to respond, both in terms of side effects for the patient, obviously immunotherapy and adding carboplatin adds more in the way of side effects for patients. But also we're talking about financial toxicity as well. Obviously immunotherapy is pretty expensive from that side. The flip side as well is actually you get a much better pathological complete response rate. I mean, the triple-negative breast cancer patient comes in at about 65%. And the data as we're talking about, actually, there's follow-up data to this now showing it has correlated with event-free survival and overall survival data as well. So it is a surrogate endpoint for those as well. Even back in 2010, but this was then formalised in 2020, actually, there's recognised that there's a group that kind of sat in between the triple-negative and the ER positives that didn't quite fit, and it's now been formalised as the ER low group. And again, so it's an ER positivity of 1 to less than 10%. And in the Aldred system, that fits with an ER3, although clinically we also use ER4. Actually, we kind of put that into this ER low group as well. Moderate number of patients involved with this, about 2 to 5% of all breast cancers. And the question then is, what do we do with these patients? They're sitting in between the two. Do we treat them as ER positive or do we treat them as triple negative? Again, as I said, there's quite marked differences in how we do that. If you do actually look at the characteristics of this ER low group, they do seem to be much more similar to the triple negative breast cancer. So this is a comparison looking at various aspects. So things like tumor infiltrating lymphocytes, again, which tend to be higher in the triple-negative breast cancer, which is, again, why the immunotherapy seems to work better there. These seem to be much higher in the ER low group and similar to the triple-negative group. Things like the Ki67, again, more proliferative in the ER low group, similar to the triple-negative compared to the ER positive group. Pathological complete response rates, again, these numbers are a little bit old, and the actual absolute numbers are lower than we see currently. But you can see the pattern again that actually for the ER low group, the response rate is much more similar to triple negative than it is to the ER positive. So clinically, we've started moving towards this, and this was again reinforced. There's two studies, phase 3 studies published last year in the ER positive, HER2 negative breast cancer, again, looking at chemotherapy versus chemotherapy plus immunotherapy in the neoadjuvant setting to see whether there's a benefit of adding the neoadjuvant immunotherapy. And both studies were positive for the intention to treat population, but when they did the subgroup analyses, they could see actually that it was the ER low group that benefited much more from this. And so this is one of the studies, Keynote 756, and you can see the magnitude of benefit is much higher for this ER low group, the less than 10% positivity compared to the ER positive group. There's another study, 7FL, Checkmate 7FL, and which showed something similar. They also looked at the 50% cutoff as well, and again showed that ones which were kind of intermediate, so less than 50%, also did better not quite the same magnitude as the lower 10%, but again, the higher numbers didn't seem to respond as well. So there's clearly a gradient of response as you come down with the ER positivity. So the question then is this in this ER group, and actually can we really predict who actually is going to respond well to the chemoimmunotherapy and who actually can actually benefit from just, say, chemotherapy alone in that situation? And that was the starting point for this study. We know that actually the data has been shown that actually there's a bimodal distribution of ER positivity, so you get a lot at the negative, true negative end and a lot at the high positive end, and then there's a middle bit which there's lower numbers for it. And the concordance actually from the mammotype is high at either end. But actually, again, there's data, I think we may be coming to see it, actually show that in the ER low group, that discordance isn't quite as high again. So the question comes up from this again, actually, if you've got a discordance between the immunohistochemistry and the mRNA, can you use this to actually predict who we should be treating, how we should be treating people? So the study design, this was a retrospective single-centre study done at Barts Health in London, 40 patients involved, ranging from the ER0 and so ER negative, so 0 and 2, and then the ER low, ER3 and 4 patients. These patients who had had standard of care treatment, that had either chemotherapy or chemoimmunotherapy as determined by their treating physician, and they'd completed their surgery. So we had we know whether they had a pathological complete response or not. As I said, 40 patients in total, 29 of them had chemoimmunotherapy, 11 had chemotherapy alone, distributed like this. In terms of actually how the distribution of, the majority of these were stage 2 breast cancer patients, particularly 2A, so node negative, 45% were node positive from that side. Just over 70% of them had immunotherapy as part of this. So if we look at the concordance rates to start with in this in the 40 patients, and that you'll see that actually we kind of heard about with the PRs again earlier. The mammotype picks up or detects patients which are more likely to be ER negative from this side. So by immunohistochemistry, 50% were ER negative. By mammotype, 75% were negative. And this gave a concordance rate of only 65%, so bringing it down compared to what we've seen. Again, in our testing, the PR, most were negative in this, again, indicating not perhaps the same endocrine sensitivity as you might expect with the higher levels, again, fitting more triple-negative breast cancer, but again, a high concordance rate. And again, in the KR67, in this particular case, actually was fairly concordant between them, and mostly positive with a cutoff of greater than 20%. So I'll show these data. This is looking at the pathological complete response rates. This is looking at the patients so the top graph is looking at all the patients who had chemotherapy and chemotherapy and immunotherapy. And but if you look actually at the patients who had the chemotherapy IO, these are very small numbers. I'll just caveat this by saying, but actually again, is there an indication here actually that in this low group can actually mammotype indicate those who are more likely to go on to have a pathological complete response, so 60% versus 33%. Small numbers, very much preliminary data on this, but again, something indicating actually can we use this difference between mammotype and the immunohistochemistry to actually leverage this to identify patients who will benefit from particular types of treatment. In conclusion, similar pathological complete response rates. Again, this is clinically happening now across the board. The ER low patients' tumours has now been treated as triple-negative breast cancer. Mammotype, again, with this ER group, they tended to classify more as negative, and there's a discordance there. And then there's this trend, again, small numbers, but towards whether it predicts a higher pathological complete response rate in the ER low group. But again, we need a larger study to validate this further from that side. And just again, an acknowledgement, I didn't do this by myself. I worked closely with Maduri Warren and Marianne Grantham in our pathology department. And I had two excellent helpers from Alison Byrne, who's one of our registrars, and also Karchai Sit, who is one of our medical students who did the bulk of this work. But thank you.